Welcome to this episode of Gender Equality Talks or GE Talks. We are indeed privileged to have with us today a very special guest, Professor Dr. Amita Pandey from the Department of Obstetrics and Gynaecology, King George's Medical University of India. Besides being a renowned gynecologist, Dr. Pandey is also a master trainer for India's most populated state, Uttar Pradesh's State Innovation for Family Planning Services, or SIFPSA as we call it, and one of the very few obstetricians and gynecologists who also specializes in medical genetics. She is one of the academic editors of the prestigious Asian Research Journal of Gynaecology and Obstetrics. Welcome, Dr. Amita Pandey.
Thank you so much for having me on board.
No, it's indeed a privilege for us, for you to find time from your super busy schedule. Dr. Pandey, from your experience as a renowned gynecologist in a public health hospital, have you come across instances of antibiotics and antiviral drugs which are used for treating sexually transmitted infections, as well as bacterial and viral infections like tuberculosis, HIV, urinary tract infections in women becoming less effective or totally ineffective due to the bacteria and viruses becoming resistant to them?
In fact, it's a very interesting debate that we are planning to discuss today, because apart from analgesics, in my clinical practice, I have felt that antibiotics are the second most abused group of drugs in India, at least. And in our clinical practice, ours being a tertiary care center, we get patients who are referred from all levels of healthcare services, right from the tier 1, tier 2 to the hi-fi private hospitals and the small private clinics. We get referrals from everywhere. And I would it's a shame that we have to say that antibiotics are prescribed right, left, and center without indication and without any appropriate need for these antibiotics. And as a result, it is very common for us to get antibiotic resistance in most of the women who report to us for care. In fact, whenever these women come to us, at the slightest doubt of infection, we have to start with very high-end antibiotics, because in our clinical experience, we have seen that the lower rung antibiotics are actually of no use, because these women have been using it right, left, and center for a very long time, and hence are resistant to most of them. You are muted. You are muted.
Sorry, yes. That's a scary situation, Dr. Pandey, but that's the reality. And then women who are coming to the hospital, say during pregnancy, abortion, or childbirth, then are they at increased risk of exposure to antimicrobial resistance while in the hospital?
Yes.
During treatment?
Yes. This is again a very interesting question that you have put to me, because, it's a double-edged sword. When these women come to us for, say, an abortion, because even in the era of modern antibiotics, you must have seen that induced septic abortion is one of the commonest causes of one of the important causes of maternal morbidity and mortality also. So let us take that example. Suppose a woman reports to a place for an abortion. The place has improper aseptic asepsis, and the practices used are also not appropriate. So to cover up that, the women are usually administered broad spectrum antibiotics, and that too for a variable period of time. Say if she stays in the hospital for 2 days, they are given the injectable antibiotic for 2 days, and then they are prescribed the oral antibiotics. But when the woman goes home, she feels that I'm fine. Why should I waste my money on these antibiotics? And as a result, there is this antibiotic resistance. So the same scenario happens whenever they deliver or they have undergo a cesarean section at whichever level of healthcare they go to, because most of the places, it's a shameful thing for us, but most of the places do not have appropriate asepsis as per recommendation. And as a result, most of these obstetric interventions do not require antibiotics. For delivery, the recommendation is just one shot of antibiotic. But believe me, even at a premier tertiary care center like ours, we cannot do that because I think the asepsis is not up to the mark. And there are innumerable number of reasons for this. But yes, we have to agree and admit that women are exposed to resistant infections while in the hospital for obstetric interventions like a suction evacuation or a DNC or an MTP for an abortion or a normal delivery or a cesarean section or any other gynecological procedure that they come for.
So actually, ICMR has set up some antimicrobial use guidelines, and it seems that they are not being followed by most of the hospitals in the public and maybe private sector. I had just read about a study where it said that the ICMR guidelines recommend administration of single dose of antibiotic for surgical antimicrobial prophylaxis for elective obstetrics and gynecological surgeries. But there have been documented instances where women receive therapeutic antibiotics for 7 to 10 days instead of the recommended dose, as you had said, that sometimes they need just one shot of it, and but they are given more. So, which means that those guidelines are not being followed, although they have been framed.
Yes. The ICMR guidelines, as you must have read also, are very robust guidelines. And they have categorically classified the antibiotics, like what antibiotics have to be used at what level of healthcare has been outlined, and then special permissions. So in fact, these guidelines have to be adopted by the institute. Like in our institute, we have a very strong antimicrobial policy. So whenever a woman reports, we do start her with broad spectrum antibiotics, but most of these are referred women. And the cases are usually botched up. And whenever a woman has to visit 2 or more hospitals, chances of sepsis increases. So in these women, we are scared about using a single dose of antibiotic. We do use a single dose of antibiotics in women who are booked at our center and who visit our center at the first place. But women who are unbooked and are referred from outside need broad spectrum antibiotic for a longer duration. But even that, all institutes must have their own policy, because our institute also has a definite policy that first level we can start with, say, ampicillin, gentamicin and metrogyl, and then if she does not respond to that, if there are signs of sepsis despite using this, then we go to the next higher level, which would include the ufloxacins and the ciprofloxacins, and then if that is not useful, then we go to the higher level like the ceftriaxones, and then the imipenems and meropenems. So, but the unfortunate thing is, most of these, the 70 or 80% of the patients reporting to the hospitals who have a very robust antibiotic policy have already visited other hospitals and are referred cases, where they have already received high-end antibiotics like nothing less than ceftriaxone and cefoperazone sulbactams and piperacillin tazobactam. So once a woman who has received all those antibiotics is referred to our center, as a last resort, we have to start some higher antibiotics. This is the unfortunate part. And as a result, we also very strongly feel that this is a very interesting thing that you have brought up, and there must be very strict, rigid guidelines about who can prescribe what antibiotics, and the OTC, the over-the-counter sale of antibiotics, must be banned as it is abroad. Because unless that is done, there would be people who would be prescribing it, because it is not just the MBBS doctors who are prescribing the allopathic medicines, but more so the homeopaths and the Ayurvedic and the Unani doctors who keep prescribing these medications. So the best thing, which in my understanding, would be to ban the sale of antibiotics over the counter.
Yeah.
Because that is the major problem that is leading to this. And then different level of hospitals should not be allowed to use all antibiotics. Say if a woman is at a PHC or a CHC, there must be standing instructions that only ampicillin, metronidazole and gentamicin can be given. Only if she does not respond, then on request, on written request, other antibiotics, higher antibiotics should be made available to these women.
Okay, so I think what you're trying to say, and rightly so, is that there should be implementation and proper implementation and checkpoints in place in all hospitals and clinics across India's healthcare system to avoid irrational use of existing antimicrobials.
Absolutely.
Because a few hospitals having these guidelines and antimicrobial stewardship programs in place is not going to solve the problem. It has to be uniform implementation.
Yes, and universally everywhere in India.
Yes, then only will you be able to mitigate this problem. And of course, from what you have said, it seems it is important to do drug resistance profiling before starting treatment. Not only in the case of women, but elsewhere, not only for obstetrics and gynecology. And is it done routinely? A drug resistance
no, it is drug profiling, resistance profiling is unfortunately not done everywhere, because to know the culture and to get the culture and sensitivity, it takes a minimum of 72 hours. Most of the time, the patient gets anxious or the doctor gets anxious or things go out of the hand if one waits for 72 hours. So the best is, in tertiary care centers, at least I know, the moment a patient comes with suspected sepsis, all the specimen samples are sent for culture and sensitivity, and then only some antibiotic is started. That is the only way that is possible. Or for that matter, we should know that which organism is prevalent in that area. Say, for example, urinary tract infection is very common in women of all reproductive and postmenopausal age. So for UTI, the recommendations are that the wild type in the field, if you get infection, nitrofurantoin must be prescribed. And only if the woman, and 90% of the cases, the woman would respond to that. That is the first line antibiotic and recommendation. Only if she does not respond to that, should she undergo a culture sensitivity, and appropriate antibiotic should be given according to the culture sensitivity report. So I think guidelines should be framed for everything, different infections like this only.
Okay, so coming to hospital-acquired infections or secondary infections, as they are called, are patients sometimes prescribed unnecessarily high doses of antibiotics to reduce these hospital-acquired infections? And instead of improving upon infection control measures, this is increasing the chances of AMR or antimicrobial resistance spreading more and rendering existing drugs ineffective or less effective.
Yes, absolutely. Except for the established hospitals, there are innumerable number of smaller hospitals and like PHC, CHCs, where hospital-acquired infections are very, very prevalent, and women are given antibiotics, especially in the private centers. They are given a lot of antibiotics because nobody wants them to have sepsis. To prevent that, they are given high-end antibiotics just to take care of any hospital-acquired infection that they may contract during their stay in the hospital.
So, as you have said yourself, and as it is a known fact that India is considered the epicenter of global antimicrobial resistance crisis.
All the superbugs we have that are resistant.
Right.
The MRSA resistance is well known and most prevalent in India.
Yes. So Although you have spelled this out, but I would just like you to recapitulate that what according to you can be done at the level of healthcare providers as well as healthcare receivers to reverse this trend of antimicrobial resistance spreading.
For healthcare providers, any prescription of antibiotics should be done with with utmost care. One must always ensure that the simplest form of antibiotic is prescribed to the patient who has come to the hospital for the first time, instead of prescribing a high-end antibiotic. But unfortunately, for so many reasons, we know that does not happen. That is why I was saying that the intervention has to come from the government. And that is why I mentioned that it is not just sufficient to make guidelines. It is very important to enforce those guidelines and stop the availability of drugs, these antibiotics over the counter, and so many other drugs also. So antibiotics also should not be available over the counter. If people are not able to get it, they will stop prescribing it, they will stop using it. So I agree that care must be taken at the level of the treating physician. Care must be taken at the level of the recipient. But most of the time, the recipients are illiterate. Even if they are literate, everybody may not have any idea about what antibiotics are needed and what is not being given to him or her. So it is very important that we, besides having robust guidelines, we have a system or a law to enforce it in all the hospitals universally all over India. Because at times we have seen that if patients come, like for pelvic inflammatory diseases, that is very common. So for pelvic inflammatory disease, the first line of drug that is prescribed is doxycycline. But if you do not, so in government hospitals, I know about my hospital, when a patient comes to our hospital, we have very strict guidelines and we all follow the WHO empirical dosage and guidelines for PID and all RTIs and STIs. So, but when we do that, and we also have those free dawaiyan also, we give them those kit 2, kit 3, kit 4, kit 6 as it is needed. But the patients do not like that. Most of the patients I know, they say कि यहाँ तो कुछ हमें मिला ही नहीं, कुछ injection लगाया नहीं. They are more satisfied if they get those high-end antibiotics, which naturally they go to another hospital, a private setup, and then they demand an IV antibiotic, and the doctor complies to their demand. So that is why it is very important that we have strict rules. In fact, as they say, it's if you don't have a stick, then enforcing things would be very difficult in a country like ours. We have very good guidelines. We have Indian guidelines, Indian protocols for everything. But unfortunately, the number of people who are following it is very, very less. For so many reasons.
Implementation is
yes, implementation is a problem.
Dr. Pandey, your message for the International Conference on Family Planning, which is to be held in Thailand this year.
Yes, it's such an important conference. And I think, especially in all developing countries, more so in Southeast Asia, the focus has to be reshifted to control of population. Why I'm saying reshifted is because in India, the government, in an effort to reduce maternal mortality, the government ensured that at least 90% of our women deliver in the hospitals. And for this, they offered a number of freebies, like included in the JSY and the JSSK, the Janani Shishu Suraksha Karyakram and the Janani Suraksha Yojana. So that is all very good. Now we have many women who are reporting to hospitals for deliveries, and home deliveries are very, very less now. That is, I think the government should get a pat on the back, but the adverse effect of this has been that everything is available for free, and the woman also gets some money for every delivery. So family planning has taken a back seat. That is why I am saying again that the government has to shift the focus back to control of population. And this, I feel that this can be done by restricting freebies to those with only 2 children. Besides that, if they come for the delivery of the 3rd child, then all the freebies should be stopped. All the free ration and everything should be given just for those with 2 children, not more. Unless we do anything, again, that stick policy has to be implemented. Unless it is done very strictly, this would not be successful, because the scenario of family planning, especially in India and other South Asian, East Asian countries also, is very, very dismal. Like, to tell you the truth, male sterilization is, the percentage is shameful. We don't even like to say that. So we have to incentivize permanent sterilization, both amongst males and females. In fact, we have to incentivize the males more if they come for permanent sterilization, and penalize those with 3 or more children by not allowing them government jobs, by not allowing them freebies, by not allowing them to contest elections, and so many things. Only then family planning measures would be effective, because I think if the problem has to be sorted out, the population has to be reduced. So my message is, let us all join hands and work towards reducing this ever increasing population, especially in India.
Yes, very rightly said. And also remove the onus of family planning from the women's shoulders.
From women to men. Absolutely. Yeah. Absolutely.
That is important.
Very important.
So with this, we come to the close of today's very, very informative and enlightening conversation with Dr. Amita Pandey in the lead up to the International Family Conference ICFP 2022 that will be held in Thailand this year. My sincere thanks to Dr. Pandey for finding time from her super busy schedule to share her valuable insights and make us more informed about the importance of sexual and reproductive health, as well as about the perils of antimicrobial resistance that has already triggered a global health crisis. I would also take this opportunity to remind our listeners that CNS has launched Gender Equality Talks live series because of our deepening realization that unless we ensure gender equality and human rights for all people of all sexual orientations and gender identities, we cannot deliver on the Sustainable Development Goals. The only possible world order which is socially just and ecologically sustainable for everyone is a feminist world order. So do we believe.